Hey everybody, glad to be here and glad to be able to come and always very happy to come back to the Farley Center campus. I've got a lot of history here and it even goes back to before I was on staff here. But now I am the co-founder and director for the Virginia Center for Addiction Medicine in Richmond, where I live. And we are an outpatient, comprehensive outpatient treatment program, basically, essentially. But lots of history here. It's always fun to come back. I see some familiar faces, a few, and some that I've never met before, although I see some clues about kind of what you all do and who you are by those lanyards and cards and things. How many of you here are are counselors or therapists? Are clinicians in mental health or addiction? Okay, that's what I figured, the majority. Are any of you medical providers, nurses, doctors, nurse practitioners? Okay, good. And administrators from treatment programs, maybe, not sure what fills out the rest, but yeah. Teacher, great.
To date with this
Excellent.
It's going crazy. You know, the new meds coming out.
Yeah. This is a very important topic right now, and I'm going to approach this in a particular way. There's a lot of discussion to have about this concept. Some of it basic science and pharmacology and clinical practice, medical practice, but some is philosophical and strategic and has to do with treatment systems and the way that we understand the disease of addiction, the way we approach that disease. So I decided that I would approach this broad topic from my own particular interest, the things that matter to me the most about MAT. We're going to talk a little bit about the basics, the building blocks of medication-assisted treatment, which is what MAT stands for. The medicines used, how they work, what they are supposed to do, and how people use them. But we're going to spend also a lot of the second half of the talk about how they can be a part of the future of addiction treatment, some of the problems with these medications, some of the reasons that there's controversy and hesitation, some philosophical and some practical objections to using some of these medicines. And some of my thoughts about the addiction treatment system that I feel we are building now from some basic building blocks for the future, and how MAT I think can play a role in that. And the way I'd like to do this is we're going to start off with just some sort of context. There's my title. I wanted you to know that I am more than happy and actually eager to talk about not just the benefits of medication-assisted treatment, but the problems of MAT. And we will save a lot of time at the end for questions and discussion. At first, though, I want to sort of create some framework, some perspective, some background information that will help shape our thinking about the rise of MAT and really the rise of medical involvement in addiction treatment. Addiction treatment has, for the last 20, 30, 40 years, has mostly been the province of counselors and therapists and mental health professionals, also peers and 12-step organizations and where those things kind of blend in together. It's only been really the last 10 years that the physician has begun to become a truly active part of addiction treatment, and that's just continuing to gain momentum and to grow. And for me, professionally, I in a lot of ways represent that movement as a member of the American Society for Addiction Medicine. And so in a lot of ways, I really want to talk about MAT from the perspective of a physician, knowing that I'm talking with a lot of mental health professionals and counselors, people who have been really doing the heavy lifting for the last 20, 30 years, 40 years in addiction treatment, and to whom this MAT movement, this medical movement, is kind of new and maybe a little bit concerning. And then hence my topic. Our objectives today, and these have kind of, I have to apologize, these have kind of evolved as I've been working on the presentation. But I want to review the opioid crisis. It's really very familiar to, I'm sure, everybody here, old news somewhat. Still going on, though. But I think that that's critical in the way that it shows us things about our treatment system, the way we approach this terrible disease. And it gives us context to talk about MAT, what it is, what are the medicines, how do they work. I want to talk about how MAT is supposed to be practiced, the evidence supporting it, the guidelines that come along with it, the standard of care, ideally. But then I'm gonna also delve into, and save this number 4 and 5 for the second half, because that's where we'll really want to talk. I want to delve into some of the dilemmas around MAT, some of the questions, the concerns, the challenges about it. Because I think, only really by challenging an issue can you come away from it really knowing the value of something. If you've thoroughly looked at it from an opponent's point of view and challenged your own thoughts. And I'm going to finish with the idea that MAT can actually continue to be a great part of addiction treatment moving forward, but with the message there that we need to make it our own. We need to make it work in the way that we know is best for our patients. So, having said all that, we're going to shoot for a 10 o'clock break. I'm going to move quickly through these initial slides. And I usually don't mind, actually enjoy interruptions and questions, but let's try to get through the first part rather quickly. We'll take a break, and the second part we'll have a lot more conversation. I'll try to save the last 20 minutes for just an open Q&A session, and we can talk till you can't stand it anymore. I love this topic. Okay, so perspective, right? Perspective really, this is, you guys figure this out. There's something wrong with this picture. It's not meant to be a negative. I don't mean to say that the reality is bad, even though the beginning looks good. But perspective changes everything, right? So our perspective for this talk about MAT, we've got to start with the opioid crisis. And it's interesting to be back here, to be talking about addiction treatment in context of my career as a physician. I graduated from VCU School of Medicine in 2004, and I finished all of my graduate and postgraduate and postgraduate training. I was actually in internal medicine and critical care medicine in 2009, and all of that I did at MCV. And so I saw this phenomenon happening. I was there in medical school. Remember, I started in 2000 and heard the lectures about opioids for pain, for chronic pain, for non-cancer pain. The movement to make pain the fifth vital sign, to be more liberal with strong narcotics, to where we got to the point where we felt as student physicians and then resident physicians that we were in more jeopardy of being censured for not prescribing opiates than for overprescribing. And so I was there, and it was very real. It felt like we were doing the right thing up to a point. And then we began to see some problems. And these problems definitely were intertwined with my career and my life. But yes, there was a quadrupling of the amount of opioid prescribing over that 15-year period from 99 to 2014. In 2010, I really began in earnest to practice addiction medicine. I just did a complete 180-degree turn in my career and decided I would do something totally different. Maybe that's 90-degree, not 180, 90-degree. To do something totally different than critical care. And I witnessed this as well. I witnessed the harm that was being done by this overprescribing. I remember that it really became apparent to the general public when there was a headline, I think it was in 2014, even though this had actually happened back in 2011, where the public realized that the number of accidental deaths caused by drugs had surpassed everything else as the number one cause of accidental death. Definitely in younger people, but in 2011 it surpassed motor vehicle accidents as the number one cause of accidental death across the board. And that made headlines. And that matched what I was seeing. In 2011, 2012, 2013, I worked in kind of an experimental small private clinic, actually, while I was working here back in Richmond. And there was a time where we were losing a patient every week to overdose. It was terrible. It was scary. It seemed out of control. The scariest thing is that it turned out that that was only the beginning. It continued to get worse. We had 2-3 years in a row of record-breaking, not only numbers of deaths, but in the rate of increase in the numbers of deaths. 2014 to 15 to 16 and to 17, huge increases. It was initially, we think, driven by overprescribing of opioids plus the flooding of the market with cheap heroin, but then was amplified by the introduction of synthetic opioids like fentanyl being really included in drug distribution. And so it's really been a disaster out there, a catastrophe. The number of deaths, the mortality, the lives lost, the lost productivity, the lost lives. Incredible. Over 100 people a day since 2015. This is the overall curve of what we saw. So beginning here in 2000 to 2016, I mean, it's just incredible, the increase in the number of deaths being caused by opioids. But as you can see, the prescription opioids, natural and semi-synthetics, those are the oxycodone and hydrocodone that doctors mostly prescribe. They steadily increased while I was in school. They really peaked right at about 2009, 2010, and then they began to level out a little bit. But this bottom curve, this brown line, the synthetic opioids like fentanyl that were shipped in by the barrel from overseas and cut into the product that was already here, really caused this spike in the last, since about 2015, 2014. As a matter of fact, in 2016, there were a series of papers written and made very public by the CDC, by the White House, the Surgeon General, by NIDA, by World Health Organization about this opioid crisis. And so it had begun to really seep into the public conscience. And the American Society for Addiction Medicine wrote an article, an editorial in a summertime issue, 2016, calling this the AIDS crisis of this generation. And it truly had been in 2016. We were getting up past 50,000 deaths per year just due to opiates. And so what happened? I mean, how did this happen to us? Where did we go wrong? Well, we've talked a lot about how it really was spurred. I mean, we can see that a lot of it had to do with prescribing. The way that doctors were prescribing opiates radically changed in the years between 1999 and 2009. And we flooded the market with pain pills, basically. And it increased the patient exposure to strong opiates radically. So that patients who may have been at risk but didn't have the exposure now had exposure to strong opiates, and we saw a flourishing of the disease. But what's really interesting to talk about, to look at, is how the prescription rate, once we got a hold of this, once we realized what was happening, how it really plummeted after 2012 and dropped way off. Doctors and pharmacists, the pharmacy industry, the statewide database that allows us to monitor how our patients fill prescriptions, really brought about a serious change for the good in the way that we're prescribing opiates, to where we went from 2012 all the way to 2016 to levels below 2006. It really, we closed, the horse was out of the barn. We closed that barn door tight. But the horrible thing about it is it did not slow down the number of opioid deaths. It kept on going up. And a lot of this was a combination of heroin and fentanyl. And so if the bad practice, the overprescribing spurred or sparked this terrible movement, it isn't responsible for all of this tragedy. It's beyond overprescription, in other words. And as a matter of fact, at this point, overprescription is kind of a minor issue when it comes to our problem, our ongoing problem with opiates. It's funny, I get calls all the time from television channels and newspapers looking for some juicy story about a doctor who's overprescribing, or this or that clinic that was shut down, or this pharmaceutical company or that pharmacy. And I tend to shy away from those now because I feel like it's more story chasing than it is looking at reality, what's really happening right now. The prescribing practices are not the problem right now. So what else was it? What led to this crisis? Number one is just those of you who have been in the field for a long time know this is not new. This has happened before. Addiction is a terrible disease. Drug use patterns change over time. In the 70s, powder cocaine pushed heroin out of center stage. Then it became rock cocaine in the 80s, and then methamphetamine in the 90s, and heroin made a comeback in the 2000s. So trends in drug use, they come and they go, they change, but the disease has always been there, and it's always been killing people. It's just that the demographics were different this time, and some of the rate of death due to overdose was different this time. So some of this just has to do with addiction and the cleverness of the drug distributors. And these guys, they're not passive in the drug problem here in America. They're very active. They want to make money. They watch what's working, what's being sold, what has maybe become too stigmatized to sell. As a matter of fact, some believe that the decline in crack cocaine use in the late 80s had more to do with the distributors of drugs realizing that this drug had become too stigmatized and unpopular and consciously shifting to other drugs more than it did anything we did, certainly more than law enforcement. What else? Obviously, our leaders and the general public have never taken a great and lasting interest in this problem. And the news coverage tends to be sort of sensational. It's here, it's there, it's a big deal, and it kind of fades away. Most of that has to do with the fact that addicts we aren't very sympathetic targets of movements or causes. We talk a lot about looking towards the AIDS crisis and the campaign to bring good research and good treatment to bear on the AIDS problem. A lot of the same stigmatization that happened in the gay community in the 90s with trying to fight HIV, we face a lot of those problems now in trying to fight addiction because, as addicts, the manifestations of our illness is not pretty. And so there's not a lot of public sympathy out there, but it's mostly based on misinformation and stigma, and that's always been there. It's not just the overprescribing by doctors, but it's the fact that the mainstream healthcare system, physicians, nurses out there in general, even psychiatrists and counselors in general, don't know a lot about addiction, don't understand it, don't really know it when they see it, don't know how to deal with it, still talk about it as a matter of good or bad behavior. And that's a real problem. Imagine how we would have acted differently in 1999 and 2000 if we appreciated the risks that even the good people face if they're exposed to high-dose opiates over time. We could have really prevented a lot of tragedy, a lot of heartache. And this is still going on today. There's really a lack of education certainly in medical schools, and I think the same goes for pharmacy, for dentistry, for nursing. And then this is a little bit more difficult for us to grapple with. The fact is that the status quo of our treatment industry is not as good as it should be. It was not prepared to handle this crisis. We saw the crisis coming. I mean, I felt it. But even in 2011, 2012, where it just seemed like it was all around and young people were dying left and right. we had no response. We had no answer. We weren't ready for it. We didn't have anything ready to handle it. We didn't have troops ready. We didn't have training. We didn't have resources. And so in 2015, a group of statisticians put together the data that we had collected and the current situation with the opioid crisis, and the proposals that were coming kind of late to the game, or late to the tragedy, of how to respond to this opioid crisis. And they used those and their statistical models, which are incredible and way beyond my understanding, to make some predictions about what would happen depending on how we respond. And they created these 10 curves where you see here in 2015, the number of deaths due to opioids was about 34,000 that year. And projections ranged from, in 10 years' time, that we may get close to 100,000 deaths due to opioids, all the way down to we may see a serious reduction on this bottom line. And what you see here, what these different curves represent at the top, is if we did nothing different than we were doing. So that represented the status quo in 2015 in our society-wide, healthcare system-wide, addiction treatment system-wide response to the opioid crisis was nothing but worsening and to tragic levels. What we have here in the middle are curves that are taking into account public health measures to reduce deaths due to opioids. And we're just talking about deaths here. We're not talking about morbidity and financial losses and sickness and misery. It's just deaths. And so in making things like naloxone widely available, changing our policing styles, the way that we deal with people in the correction systems, needle exchanges, other public health things, all combined to create these middle 6-7 curves here that showed some modest improvements and a little bit better improvements towards the bottom. None of them had an immediate effect. The bottom two curves here, though, were the ones where we began to take into consideration the widespread expanse of treatment for opiate use disorder. And I have to tell you that a lot of that, when they defined the word treatment, was MAT. And this was clearly, in 2015, the way to go if we wanted to prevent this from happening. So now here we are in 2019. We're almost halfway to this 10-year mark. And surprisingly, fortunately, we're somewhat relieved to see that maybe the number of deaths in Virginia, at least, is finally beginning to plateau and might maybe take a downward curve. So our response is finally beginning to work. What parts of the response exactly, we're not sure yet, but it looks hopeful. It's right here between 2017 and 2018. We were concerned that the death rate would continue beyond 1,200 per year in Virginia up towards 1,500, but it didn't. It stayed static. Sadly, this is just kind of a gee whiz kind of interesting thing. At about the time that the headlines were coming out about this plateau and the new data finally was crunched for the last part of 2018, I was doing some Google searching to see what was going on, to recognize this plateau. And in the same search, I found these headlines. Of course, the politicians trying to say, hey, look what we did, and it's great, everybody, good job, we cut down the opioid deaths. But on that same weekend, in Richmond at least, there were a whole bunch of overdoses and deaths at the same time. And then I caught this headline. Did I include it in there? This one, yeah. This headline about the drug use patterns already beginning to shift to other drugs rising. And it seems like now it's stimulants, and it's oftentimes stimulants combined with fentanyl causing deaths out there. So once again, the drug problem, it doesn't go away. It's not about the drugs. The problem is deeper than that. It's always been part of human society. The problem isn't the drug. We like to, in popular culture, we like to focus on, oh, what is this new evil drug? Let's talk about it as if it's the cause of all the harm. Let's focus on this new spooky drug. And again, the reporters are always looking for those kinds of stories. But it's harder and less glamorous, maybe less exciting, less easy to understand, but the truth to say that it's not about the drugs. The problem is in here. The problem is the disease of addiction, and it's in the brain. And that's very pertinent when we start to think about what we've gone through here with the opioid crisis and how we're responding. I think it's quite fortunate that people are paying attention nowadays to addiction treatment. There's been an equally attentive response with the current administration in the White House compared to the last, which was good, it's a relief. There's still a lot of support here in Virginia, a lot of funding towards treatment. I'm glad that this has been a result of the tragedy of the opioid crisis. But those of us who have been around addiction and addiction treatment for a while know that the disease is not going to go away with the opioid crisis. It's going to continue because it's in the brain. It's a brain disease. It's a brain problem. It's always been with us. So, joke, if addiction's a disease of the brain, how do we fix it? We gotta fix the brain. So this is, kind of the way surgeons think, the way doctors think. Some cockamamie approach to fixing the brain, which is kind of it's apropos, being that I'm again sort of a physician. I sort of see myself as an interloper a little bit in the addiction treatment system. Presently, I'm kind of a novelty. Doctors tend to think in mechanical and direct terms, and we want to prescribe medicines. We want to do procedures and surgeries. We want to fix the problem, move on to the next one. And this is not going to be that simple. Obviously, it's not going to be that simple. But what's clear is that treatment is got to be the main focus of our response to the crisis. I believe in public health measures. I believe in harm reduction. I believe in the holistic approach with reform in the way we enforce the laws about drugs. But I think it's pretty clear that if we really want to tackle the American drug problem and really have an ongoing solution to this human problem, it's treatment. Treatment's the answer, clearly. A lot of you are probably very familiar with the common statistic that SAMHSA publishes saying that about 10% of those who struggle with opioid or with substance use disorders, about 10% who need help, who meet criteria for the disease and need help, 10% will actually get it. And that's a lifetime number. In their lives, only 10% will eventually get the help that they need, which is terrible. And it's not like we're talking about a rare illness. We're talking about a very common illness. It's not far behind diabetes in its commonness, its prevalence. It's more than emphysema, and yet there's really not nearly enough treatment for this illness. The other thing we know is that the treatment works. And then the last Surgeon General, made a statement with the release of the white paper from 2016, saying that we know treatment works. There's just not enough out there, and that's true. But it's not the whole story either. Once again, it's a little more complicated than that. The truth is, not only is there not enough treatment, but treatment isn't good enough yet. Treatment needs to be better. We weren't ready when the opioid crisis hit us. We weren't ready to ramp up treatment. We didn't have the capability. And the truth is, the systems that we had in place, the resources that we had in place, the Farley Center's always been here all that time. It saved a lot of lives. But when you look at the size and scope of the problem, we were not ready. Our system was not good enough. problem number one, and think about this, and we're going to talk about this a little bit later when we have time to discuss, but I think that you'll agree with the things I list as being fundamental problems with our status quo, our current ability to treat addiction. Problem number one is that part of the disease of addiction is that you don't want to admit you have a disease. You don't want to get treatment. You don't want help because you don't want to admit that you need it. And that's one of the things that makes it just so darn difficult to treat. Regardless, though, if we're talking about 8.5% of the population in the U.S., we're talking about like 25, 26 million people. And if only 10% of those are getting treatment, there's 22, 23 million people who need treatment and aren't getting it. Whether or not those 23 million can't get it or don't want it or just don't want it enough, the bottom line is they're not getting it. And so the problem is not just that it's not there, it's that people aren't engaging in it for whatever reason. Another problem with addiction treatment, and we're just looking at this very objectively, kind of removing ourselves from things that we're so familiar with. If you were an outsider looking in, if you were a young, say, a young counselor in the beginning of your career, sorry about that, trying to figure out what you're going to do, if you're a doctor looking at the current problems that Americans face and looking at the possibility of getting into the field of addiction medicine, one of the things you'd have to notice is that treating addiction's tough because it's really hard for people to get better. And most people don't get better the first time that they recognize the illness, diagnose it, and recommend treatment. It usually takes years. It takes coming in and out of treatment. It takes relapse after relapse. It takes long periods of struggle and pain and growth. And it takes a long time even for people to first engage in treatment, even after they know they've got a problem. And that's difficult. And then even after that, even when people do engage in treatment, our results aren't that good long term. We don't have a great rate of success. Interestingly, I think, I just threw this in there, one of the few cohorts of patients where we do have a lot of success are health professionals, physicians, nurses, pharmacists, counselors, people with healthcare licenses who have to enter into long monitoring contracts in order to keep their licenses. And those folks do pretty well, and that's a whole other subject to explore. But everybody else, pilots fit into that as well. They also have to do similar things. But for everyone else, the success rate's not very good. In 2015, and I think even still today, certainly in 2011 and 12, when I was first looking at this crisis that was unfolding, the gold standard of treatment has always been residential treatment, like we have here at Williamsburg Place at the Farley Center. And while the experience of treating people inpatient, I had a wonderful experience treating patients here. We often made great progress with people in the time that we had them with us. But long term, how do they really do after they leave? The numbers are pretty bad. It's not good. Studies that were done in the last 20 years suggested that at 1 year, it's about 3% are still, abstinent or engaged in ongoing recovery. It's not far from what you call the spontaneous remission rate. It's almost like, in other words, it's like saying the success rate at 1 year of people who go away to treatment and then go home is about the same as people who do nothing and just hope they get better after a year. It's pretty bad and frustrating. So the gold standard is not delivering the numbers that we need. When I worked here, when I was on staff, I know we worked really hard to try to get people connected with ongoing treatment when they would leave us here. It was something we thought about from the very first day when they arrived. Okay, what will be their discharge plan? How will we set up treatment for them when they go? But even with all of that care and focus and effort and talks with the patients and agreements and contracts and great alumni programs, the truth is there's not a lot of support out there. There's not been a lot of outpatient treatment. It's a huge failing in our system. Very little treatment out there. What is out there, counseling, private practice counseling, or CSB-sponsored counseling, the occasional psychiatrist who knows a thing or two about addiction, um, the sober living industry, which is kind of just mom and pop grassroots kind of thing. It's helpful, but it's all kind of off on its own. It's siloed. Certainly, when you talk about physician involvement, whether it's methadone or Suboxone, those kinds of things they're in their own little worlds. And you go to get methadone, you're put on methadone, and there it is. That's all. So outpatient treatment, it's just not where it should be. Further, the folks involved in outpatient treatment, they don't really work together very well. They don't necessarily believe in each other as much as they should. It's all broken up and scattered and disjointed. And then ultimately, one of the greatest problems of our treatment system, and it's hard for us to remember this as professionals who are immersed in addiction treatment all the time. We do it as our jobs. We see it every day. Certainly, the staff on this campus, you live and you breathe it. But for the general public out there, the mother or father who realizes that their child who's trying to go to community college or is out of the house for the first time or still there and in high school, now has a serious drug problem. What do you do about it? Most of those folks have no idea. They don't know what it is they're dealing with. They don't know where to turn for help. They wouldn't know who to ask. And even after putting in a lot of effort, I've had people tell me how it took months and months and months to find someone who could answer questions. Certainly, primary care doctor usually doesn't know. Even often their psychiatrist doesn't know. Minister at church maybe knows something. One time I used this little phrase here because I had an experience once giving a talk at a sort of a community, kind of a town hall meeting in a church in Richmond, and it was full. This was at about 2013-14, when the numbers of opioid overdose deaths were just terrible in Richmond, rising fast. People were terrified. It was packed. A lot of the people there were the families of young people who were addicted to opiates. Many had lost people, and a father that I could tell was just distraught. He'd sat in the audience and heard me talking about how we can't arrest or punish our way out of this problem, that treatment's the answer rather than punishment, and treatment this and treatment that. He raised his hand and asked me, "But sir, you keep saying treatment's the answer. What's treatment? What is treatment?" I think he might have said, "What is the treatment?" What I heard was, "What is treatment?" And at that time, 2014, I had a hard time coming up with an answer. I didn't know quite what to say. I sort of stammered and said, "Well, it's a lot of things, different things for different people. It kind of depends. There's this. And I got embarrassed. I realized that's not a very good answer. And the look on the man's face showed me that he wasn't reassured by my answer. It's like, "So what are you saying? Send him to AA? He didn't like it. He hates it. Send him to a counselor he's sick. He can't even sit down. Can't sit still for an hour. What are we supposed to do? What is treatment?" And it made me realize professionally that even though I had decided this was going to be my career, addiction treatment, that we don't have a standard of care. We don't have a single body of knowledge that we trust, that we all contribute to, and that we prove with evidence to be effective and that we follow and change and grow. Like in other healthcare fields, we don't have that. And that's a problem, because that means that quality of care can greatly vary. People don't know who to look to, who to trust. The standards are different in different parts of the country. And there's a lot of victimization out there, people being offered expensive treatments that don't really help. So that's a problem. We don't know what is treatment. We often say there's a lot of pathways, which is good, I think. I jokingly asking, is that good? Because it also shows that we're still figuring this out. We don't know exactly why certain things work for this person and other things work for another. We like the fact that people can find their way to recovery in lots of different ways, and we've got to be open-minded about it, but it also sort of reflects our quandary that we don't really know what treatment is. Now, I think that there's a lot of wisdom out there, especially in a group like this, where a lot of you have been in this field for a long time. There's a lot of knowledge, there's a lot of wisdom. But the time has come for us, for you, for us together to get together and decide what is our standard of care, what works, what do we believe in, what should be included in the manual that trains the next generation of addiction professionals. In order to do that, I think we've got to take a step back and ask ourselves, ask each other, what makes treatment work? Treatment works, yes. Vivek Murthy, Dr. Murthy, the Surgeon General, said it himself. Treatment works. We know what works. It's just not enough of it. But how does it work? Why does it work? We know we've seen successes. We've experienced success. But what was it that got us there? And this is something that I like to think about a lot, and I thought about a lot as I worked on creating my own treatment center. I think we can all agree that everybody who has a chemical dependency, substance use problem, or even a process addiction, everybody needs these essential things. When they're starting from just the realization they've got a problem, they can't fix it on their own, they need help. Problem is addiction. They need to be physically and mentally well. They need to not be dependent on the drug that they're abusing, not getting high. They need to be stable. They need to be able to feel okay. And that means both physically, as far as dependence on alcohol or drugs. It also means mental health. It's so that that depression and anxiety are adequately addressed and are doing better. So that's a basic fundamental thing. They need knowledge. They need to learn things. What do we put people through here at Farley Center when we get new patients in? Tons and tons of teaching and knowledge, lectures and books and reading and study, because you've got to understand your disease in order to get better. So we know that's part of it. They need to be held accountable. They need to get a lot of emotional support. They need to be shown a lot of empathy. We know this is true. They need some practical help. They need guidance. This is why it's been so beneficial to have social workers and caseworkers involved in addiction treatment, because they can help solve practical problems like, how do you get a job when you have a felony? How do you get your driver's license back? How do you find an apartment when you haven't really ever done that before? They need experience. They need to be able to live the recovery experience and feel the feelings of recovery, have successes, overcome problems, deal with challenges. They need to be able to do that with help, and they need to have people to teach them and share with them and train them how other recovering people do well. They need recovery habits. They need skills. They need to learn how to make the right decisions. They need to cope. And then most of all, I think we'd all agree, they need time. Time is one of the few really always present components of recovery from addiction. They need time. All these things are important. But so given that this is all of the stuff is baked into treatment here at the Farley Center, it's certainly part of addiction treatment out there in the community. This is not really controversial, but where does MAT fit into this? MAT, or medication-assisted treatment, it's fairly new. It probably started with methadone in the 1960s. Methadone really didn't even come to Richmond until the late 80s, early 90s. And then in 2002, Buprenorphine was approved for treatment of opiate use disorder, added one more tool to the MAT movement. And somewhere in there, I'm not exactly sure when we first began to use Naltrexone, first for treatment of opiate use disorder and then later for alcohol use disorder. This is a completely different kind of approach to addiction compared to this more holistic sort of a thing we're used to, this uncontroversial. And so our question today, the thing that I really want to dig into in the next hour, is how can this growing movement that directly seems to help people get better but doesn't quite fit into some of our philosophical traditions of treatment, how are we going to accommodate this? Does it help? It's saving lives, so they say out there, and a lot of us see it. It's saving lives, but it's causing, I think, quite a rift in the world of current, present professional addiction treatment, between those that see it as simply harm reduction versus what they do, which is to focus on treatment of the illness and recovery. What is MAT? Well, basically MAT is the use of medications that interact directly with the chemical receptors in the brain in the systems that have to do with addiction. It's the most direct thing that we have as a tool, direct meaning almost mechanical, physical, real, in intervening in the disease of addiction. The most common examples, as I mentioned before, are methadone, naltrexone, which is sometimes given in tablets, more and more today given as an injectable called Vivitrol, and buprenorphine, which is most popularly known as Suboxone. They were introduced to us, starting with methadone, as a part of treatment, as something to be used in conjunction with everything else, with all the counseling and the teaching and the casework, with the accountability and the monitoring and the support. They don't treat the disease of addiction. We know nowadays where the disease of addiction is. That was something we didn't ever quite know before. We know that it's in the brain, and nowadays we know that not only is it in the brain, we know which parts of the brain are not working right in a person who has the disease of addiction. We know which circuits those parts of the brain are involved in. They have a lot to do with our ability to feel pleasure, to have desires and drives and motives, and to seek out feelings of reassurance, things that are very fundamental to the human experience. We know where they are. We can point to them on scans. We still don't have a way to get in there. We wouldn't even know if we could, to stimulate this part or adapt that part or introduce gene changes in different circuitry. We're not even close to that. But we do have these medications that act in those circuits in one way or another and seem to help people get better. But how do they do it? Naltrexone. How many of you here are familiar with naltrexone? Okay, good. I thought it would be a lot. That tells me a lot. Naltrexone is an opioid receptor blocker, and this little cartoon kind of demonstrates the three drugs that we're talking about, naltrexone being here on the right. Opioid receptor, and we're talking mostly about opioid receptors in a part of the brain called the nucleus accumbens. Naltrexone molecule fits the opioid receptor and blocks it from access by other molecules. So it gets into the brain, it causes an interruption in the signal at opioid receptors and prevents this explosive release of dopamine in the nucleus accumbens that's what brings about the high feeling when people use opiates. Naltrexone also can be used in alcohol use disorder, and we believe it's because in the process of intoxication and habitual use of alcohol, there is stimulation of the opioid receptors in the nucleus accumbens. There's an unusual, abnormal, amplified stimulation of opioid receptors in alcohol abuse. And so naltrexone, by blocking the opioid receptors in alcohol use, prevents the funnest part of drinking. It makes it so it's just not that pleasurable, not that memorable, not that special. Still works, but it's just not that fun. And it's proven to be effective. Interesting and important to point out is that naltrexone, even though it makes a lot of sense to a lot of us, if it can block the feeling of high when you take an opiate or modulate the feeling of high when you drink a drink, yeah, that makes sense in the way it would help a person not to be addicted to those things or to prevent relapses to those drugs. But even though that all very much makes sense, the evidence for their use is always tied to counseling. In other words, we can't recommend these drugs to a patient and claim that they will help with opiate use disorder or alcohol use disorder if they are not accompanied by regular counseling. So counseling still has to be a part of naltrexone use. Naltrexone, as I mentioned, the most common form is Vivitrol. It's a once-a-month injection. It has recently been shown to be non-inferior to buprenorphine MAT, works just as well if you can get the person started on it. The The one interesting thing about the study is that the number of people who were able to get on the drug and start the study was significantly lower than those who were able to get on buprenorphine and start the study. With Vivitrol, because it blocks the opiate receptors and doesn't cause any kind of mood-altering effect, there's no risk of diversion, there's no risk of abuse. It's a little more difficult to sell to patients, to get them to buy into it. Part of that is because if it's being used in opiate use disorder, they have to be able to get off of opiates first, stay clean for a little while, about a week, before they can safely start Vivitrol. So it's harder to get a patient motivated to do it, but it clearly works. The studies that support its use show clear benefit at 6 months and safety at 12 months. And aftermarket studies have shown that it still appears to be safe after that, but there haven't been formal studies to recommend its use beyond those time periods. But I have patients who've been on Vivitrol for 3-4 years and are doing very well. There's very few reasons to not give Vivitrol. Sometimes people are under the impression that if you have hepatitis, like hepatitis C, that you can't be on Vivitrol or Naltrexone, and it's not true. It has more to do with how your liver's doing right now. When trying to get people to get on Vivitrol, most people have worries about, what if I get hurt, I have an accident, I'm in pain, what will happen to me? What if I break my leg? What will I do about pain? Once you get a patient on it, that's usually they realize they don't need to worry about that. It rarely ever happens, and if it does, it's easy to manage. Some side effects for people who, after they get on Vivitrol, less than 10% of people report side effects, but of those that do, there's a significant number, 2 or 3%, who will decide to stop because they don't like the headache or the nausea that they get with it. For most people, it's well tolerated, definitely effective. Methadone is the granddaddy of all MAT. We're just going to go like 3 more minutes and we're going to take a break. Methadone is a pure opioid receptor agonist, meaning it fits perfectly in the opioid receptor. This is methadone, this is the receptor. It fits perfectly in the receptor, it fully stimulates the receptor, it causes euphoria, it causes pain relief, it causes sedation and all the other side effects. But the difference about it is that it's very slow onset, slow offset, and it lasts a long time. And because of those properties, if you give a patient the option of either being on methadone, which is very slow acting, or continuing to live the life of chasing heroin every day, a good number of those patients will accept methadone and stop chasing heroin. And as a result of that, their lives get a lot better. And I've seen it. I've seen it up close. Heroin addiction is so bad and so deadly that it wasn't difficult for researchers to show that methadone, take 100 heroin addicts, put them on methadone, have 100 who you just talk to and tell them you got to stop using heroin. It was easy for the methadone arm to just completely bury the willpower arm. Destroyed it, made it clear that if your goal is to get a person to stop using heroin, you're much, much, much more likely to have success if you just put them on methadone. And that's what the study really shows. There's a lot of regulation when it comes to methadone, kind of limits the availability. There's always more people who want it than can get it. But it's certainly out there. As a lot of you know, you have to come every day to get methadone. Usually you have to pay cash. A lot of methadone clinics, it's changing, but a lot of methadone clinics don't take any kind of insurance. It doesn't take much motivation to be in a methadone program. You just have to get motivated enough to go, to try not to use other drugs too much to where you get in too much trouble and get kicked out. Other than that, all it takes is just the desire to not be on heroin anymore, not want to have to do all the heroin rigmarole. And addicts, though, still struggle with it. They do. Honestly, the goal with methadone treatment is mostly harm reduction. It's the benefit of not being out there using heroin and all the bad things that can happen to you using heroin or pain pills or fentanyl or whatever it is. But in the theory of methadone treatment, there's a lot of talk about engagement in treatment practices, in counseling, and in coaching and teaching and engaging with the patient and holding them accountable, and the potential beneficial effects on a patient who gets into a good methadone clinic. But the truth is, and I think if I open this up for comments and questions, what I would hear is that what you see in reality doesn't often match what we wish we saw, or at least what we theoretically are trying to do with methadone. But it saves lives. Now, buprenorphine, we're going to talk about this briefly, and then we're going to take a break, and we'll come back to buprenorphine. Buprenorphine is different than either one of those. It's kind of in between. It fits in the opioid receptor as a molecule, but it doesn't fully stimulate the opioid receptor. It gives a little bit of opioid effect. We think about 40%, but not all of it. And while in the receptor, it blocks other opioid molecules from getting in there, so nothing else can have an effect. Another interesting thing about it is that when it's in the system, you increase the dose, its effect is less and less with every dose increase. So it has a maximum effect, a ceiling effect, where taking more doesn't do anything. And so it has a much better safety profile compared to methadone. The most common brand is Suboxone. These are the Suboxone films. It's packaged and delivered in combination with Naloxone. The true story behind that is that's to prevent IV use. The naloxone itself is only very little is absorbed under the tongue or in the gut. It's not the blocker that prevents people from using. Buprenorphine is actually the blocker that prevents people from using. The naloxone is kind of a little bit of a marketing ploy to prevent people from injecting it, melting it down and injecting it. Suboxone, buprenorphine is delivered under the tongue sublingually. That maximum dose that I was talking about is 24 milligrams. Standard for most heroin addicts, 8 milligrams twice a day, 16 milligrams a day. The absolute maximum to where there's any benefit from taking more is 24 milligrams a day. Beyond that, it doesn't do anything more for a person. Because of that dose effect, that ceiling effect, it's almost impossible to overdose on buprenorphine. The very few cases where it's happened, it was because of a combination of buprenorphine and like Xanax and alcohol. And with an opiate-naive patient. But it's much safer. This is Zubsolv, which is just another buprenorphine product compared to the old tablet and the new film. It's a lot less regulated, so there's a lot more availability out there, and it's growing all the time. There's a new product out there called Sublocade, which can be given subcutaneously and lasts a month. And I think it's got a lot of potential because it prevents diversion and selling and all that naughtiness that goes along with Suboxone use. A little bit difficult to sell to a patient. They often just have a hard time trusting that it's really going to work the whole month and they don't have anything to put in their mouth. But it also is nice for them because they don't have to bother with the pharmacy. They don't have to worry about losing it. They don't have to worry about anybody stealing it and all that. So it's got a lot of potential. The evidence behind buprenorphine's use is really strong. It clearly works. Saves lives. It gets people engaged in treatment. It keeps them in treatment. The controversy has to do with the fact that it does cause opiate stimulation, opioid receptor stimulation. And there is potential for abuse, and there's definitely dependence. Person on buprenorphine is dependent on that buprenorphine. If they stop, they'll go into withdrawal. And those things are a lot of what causes a lot of misgivings about the use of buprenorphine in treatment. Just like with methadone, but even more so, best practice is to combine buprenorphine with counseling. That's how it should go. Ideally, that's happening, on a rigorous and weekly basis. There's a lot of accountability in counseling and nurturing, ideally. But just like with methadone, what we have is set up as an ideal, and what really happens is not often the same. And I have to throw in with some notable exceptions. Down there, notable exception. You can. That's my practice. Notable exception. But yeah, what you see out there is not necessarily what the ideal is. One good bit of news on the horizon is that payers are looking for collaborations with providers who meet the standard of care. So there's a new incentive to do it right, but it's new, and it's still we're still working on it, still growing. Okay, I think this is where yeah, I wanted to just throw this up there, and this will be where we'll take a break. Some of the papers that support the use of buprenorphine and methadone in treating opiate use disorder. I've read all these papers. A lot of them, a lot of the justification for using buprenorphine over methadone was based on comparative studies that showed that buprenorphine was non-inferior and then safer and in some ways superior to methadone, and then inheriting all the evidence that supported the use of methadone for opiate use disorder. A lot of these studies are time limited. They follow the patient 6 months, maybe 1 year. But what they see in a short period of time is a lot greater success at cessation of illicit opiate use. Certainly lives saved, the death rate's much lower. The compliance and adherence to treatment is much higher. The engagement, length of engagement, much longer with buprenorphine versus non-buprenorphine therapies, counseling and drug testing. You know, when you just, if you were just to read the papers, you would think why, and I think this is what we see out there, and in the headlines and all that, why isn't everybody who has a substance use, an opiate use disorder, why aren't they all on Suboxone? They should all be on Suboxone. In a lot of ways, that kind of talk, though, is what makes the old professionals a little nervous, a little worried. And that's where I want to pick up when we come back. So we'll take a break here, 5-6 minutes, and then we'll finish the last 10 slides and we'll talk. All right, everybody, thank you for coming back. Most everybody came back. Thanks, everybody, for hanging in there. I had some great questions here at the break, and I would love to. I bet you we could probably go for an hour or two with Q&A, but I'm certainly going to try to save at least 20 solid minutes for Q&A, and I'll be glad to talk about anything. Going back to the mechanisms of treatment, practical, clinical questions, or what I'm going to talk about here for the next 15 minutes. I'll go fast. Kind of the philosophical issues that I think are also really important. Key is, I think, you know, this is not easy. Treating addiction's not easy. It's really, can be very rewarding. Most rewarding thing I've seen is to see somebody turn their life around and get recovery, but it's also really hard. And even with best practice, it's just really, it's a tough disease. But it's much better than it used to be, treatment. And I think we've got a bright future ahead. So after talking about now how it should go with buprenorphine, I thought it would be a good thing to talk about what really is happening out there. And what I'm going to see in the next 5 slides or so is my observations. This is not, I don't have a lot of evidence. I don't think evidence has been collected in these things. I would love to know about if anybody knows of papers that I could read that touch on these topics. But this is basically my observations of what is in the marketplace when it comes to buprenorphine practice, and what I think, how things can be. So right now, there is an enormous push to expand MAT. There's a lot of money involved. There's a lot of private money trying to capture market share when it comes to providing, in particular, we're talking about buprenorphine, Suboxone, grabbing up footprint in the state of Virginia. It's seen as, it's being packaged up and marketed as a cure-all almost, a magic bullet. And it's looked at by a lot of people as a great money-making opportunity. And they honestly believe, most of these folks, that it's also a way to do a lot of good. A lot of these practices out there that are going to be, you'll see them coming up. You're probably going to see billboards and commercials, and they're going to really spread across the state, trying to have a kind of a simplified method for getting as many people on buprenorphine as possible, and focusing honestly, I think, mostly on harm reduction. And that's important. Not to say that there's anything particularly wrong with that, but I think it's something to anticipate for those of you who are in the field. And I think it should motivate everybody who really cares about this topic to get involved as well, to be able to put their expertise, wisdom, knowledge, experience to bear, to offer it up to people out there, to be able to get a more well-rounded approach to addiction treatment. I mentioned to one of the questioners just now that the American Society for Addiction Medicine has really become the organization to go to when it comes to MAT practice and when it comes to physician and nurse involvement in addiction treatment. They really are setting the standard, and I think that they will grow to become like the American Heart Association, the go-to organization for for physician work, medical care, and addiction treatment. ASAM has really bought into MAT. And when I first joined, 2008, I think, guys, when I joined, it was very controversial and somewhat split. But since then, it has really moved towards the majority and a lot of the weight of ASAM is pushing towards the expansion of MAT out there, of buprenorphine MAT. There is still a small cadre of people who are really still concerned about the concept of recovery and spiritual awakening for our patients. And I happen to be one of them. And some of those doctors, not all, some still just don't involve themselves in buprenorphine MAT, but some, and I'm one of them, trying to reconcile the two ideas. So this battle is going on right now in the hearts and minds of addiction physicians across the country, and ASAM is the organization that's kind of holding us all together. Problems with buprenorphine. When you look at the evidence, as I was saying, it's pretty strong for the fact that buprenorphine saves lives, it gets people engaged in treatment, it keeps them in treatment, it's effective. But it's also got a downside, like everything does. There are downsides to this. Number one is it is often presented as the answer for opiate use disorder for all cases, and that to not be on buprenorphine is an incredible mistake. And I think that obviously can't possibly be true. One size doesn't fit all, and unfortunately with a lot of the straight MAT practices that are out there, if you walk through those doors saying, I have an opiate use disorder, I need help, it's basically, come on in, we're going to put you on buprenorphine, and that's what we do. Where our response needs to be, let's get an assessment of your story, of your situation, your history, and let's come up with the best plan for you. Sometimes I hear less now than I did at first. When I first began to practice addiction medicine, I was opposed. I was one of those opposed to buprenorphine MAT. It didn't make sense to me. I didn't understand it. It wasn't what I knew about addiction treatment and recovery. Over time, and going through those experiences I went through where I saw so many deaths, so much struggle, so many young people dying, coming into treatment, just briefly getting just the first glimpse of it and then not making it, it changed the way I see things. And I've come to be, I'm an advocate for buprenorphine in addiction treatment. But I still respect those and appreciate the objections and the concerns. One of those objections I used to hear, buprenorphine is just trading one drug for another. You're solving one problem but created a second problem. You're just kicking the can down the road. You're just delaying the person from finally recovering and getting off of drugs. There is a real risk of diversion. We constantly have to be vigilant at my practice to look out for patients who are selling their Suboxone and doing whatever. Some of them sell it and buy heroin. Some of it just pocket the money and take a little bit before they come in to see us and pass their drug test, and we have to watch out for that a lot. So there's diversion issues. There's issues of abuse. There are people who I know come in seeking buprenorphine because they just want to feel better and use it really with the wrong idea. There's a black market out there in places like prisons especially, where access to drugs is really difficult. It's there, but it's difficult. Suboxone has become the #1 drug of choice because it's easy to clandestinely smuggle those little thin strips of Suboxone into prisons, into jails, And so for those who are incarcerated, Suboxone is the way you get high, and they have all kinds of crazy ways of doing it. And so, yeah, there's abuse out there. One complaint I've heard from a more traditional provider, a therapist, is that Suboxone practices attract unmotivated people, people who they aren't ready to go to any lengths to get better. They just don't want to hurt anymore, and you're going to have a hard time having therapy with them because they're not motivated. The 12-step community is still very hesitant about buprenorphine, and there are some groups that just simply don't accept it. There are some sponsors out there who will not sponsor a person who's on it, and they just think it's absolutely wrong. The criticism that it's, for those who are begrudgingly give it a little bit of credit, will say that it's really just harm reduction, and that it might keep a person alive, but if it was your child, if it was you, is that what you would want out of your life, just to be kept alive? Wouldn't you want your child to get recovery, and be happy and joyous and free? The question being that perhaps putting a person on buprenorphine actually diverts them down the wrong path to where they get a false sense of wellness, and it actually interferes with their growth towards recovery, that it slows their recovery down by taking them down these fake feelings, this fake path that they're going to have to back their way out of, and you're prolonging their struggle. So I've heard all of these complaints, and I think there's grain of truth in a lot of them. But I want to tell you about what I've seen and observed as some of the positives with buprenorphine. Some of these are going to be kind of obvious, but some of them may be a little more subtle. One thing that's definitely also true about buprenorphine is that the people who do come in, and maybe this is just one of those perspective things, like our ship that was turned sideways. One way to look at the fact that we bring in patients who are not as motivated, say, as people who come here to Williamsburg Place and commit for 2 months of treatment. On the other hand, the people who come to treatment at a buprenorphine MAT program are likely people who would not otherwise seek treatment or would not likely accept treatment or any other kind of help. And so we see people coming in to get help who are a lot earlier in their recovery process than you might see in a residential treatment program. It definitely, and we see this is bearing out in our internal data, it definitely increases the overall retention of patients who are in the practice voluntarily, who are here because they chose to get some help. They stick with us better if they're on buprenorphine than not. Interesting thing, especially for those of you who are in practices that use buprenorphine, the longer a patient is on buprenorphine, the less effect it has on them. As time goes by, the stimulatory opioid type feeling that they might have had in the first month or two goes away, and patients end up feeling just kind of normal when they're on it. And from what we've observed in our practice, they're pretty much indistinguishable from non-buprenorphine patients. They cry, they laugh, they hurt, they cheer, and they work in therapy very well and make progress like everybody else does. An interesting thing that just has to do with the pharmacology of buprenorphine is that the maximum dose, it eventually, even if you have a hard time limiting a patient's dose to what you think is necessary, it ultimately puts a hard stop on a patient's ability to escalate their own dose. So now you have a patient who's been in your clinic for 6 months, they're at the maximum dose. They may not have put a lot of work into their recovery. They may wish that they could get that old feeling that you got at the first day they got on Suboxone. It's never going to come back again, but you still keep them with you because for them, the choice of staying in treatment and getting their Suboxone regularly and getting to come back to this group that they go to that they kind of like and this doctor that they kind of enjoy talking to, it's a lot easier for them to continue there than to go back out and use. And so it becomes it changes the calculus in the patient's mind. It makes it easier to stay in treatment. A few more interesting things. These days, most of the patients that I see, the ones that I see in the recovery community and the ones that I see in my clinic who are in recovery from opioid use disorder, especially the younger ones, almost all of them have spent some of their time in their recovery journey on Suboxone. There's been a period of time where they were on Suboxone. Most of them have told me stories that they weren't proud of about the way they behaved in their Suboxone clinic or the way their Suboxone clinic was run, that they were just taking the medicine and not doing anything else. But this is becoming part of their journey. And what that tells me is that if these folks are able to reach recovery after having been on Suboxone for a while, that there was some contribution there. We definitely find that patients who would not otherwise participate in counseling, coaching, testing, and accountability will agree to do it when the choice is about getting Suboxone or not. We find that being on Suboxone, a lot of patients tell us that it protects them, that they don't use because they know it won't have an effect. And in order to get high, they'd have to actually go into withdrawal after not taking Suboxone for a couple of days before they'd be able to get high. And so they feel like it helps them to not be impulsive and to use when the opportunity is there. And as I mentioned, it does not seem to interfere at all with psychotherapy, and it doesn't seem to interfere with 12-step processes. I find it still a little bit difficult to get sponsors of people in NA and AA to work with and do steps with patients who are on Suboxone. But for those that do, I see real success, real progress. And their attitudes are changing in the 12-step community. They're becoming more welcoming, a little bit more open. Interesting little tidbit, most patients, I think about 90%, again, this is just all internal data, who come to us seeking our buprenorphine MAT program will make as one of their goals on the very first day that they want to get off of buprenorphine one day, almost all. A lot of them don't know what it means to be in recovery yet, but they don't intend to be on buprenorphine for life, and that means a lot to me. Usually learning the things that they need to learn to be able to stay clean once they get off of buprenorphine, it's a lot harder than they expected, almost always. It takes a lot longer than they expected, almost always. I've had numerous patients come in and say, I just want to do this for 3 months, and then I'm going to be fine. And then you get me off the Suboxone, and I'll be fine. And what I tell them is, I'm really glad that getting off Suboxone is part of your goal, part of your plan. I'm glad that you want to recover and eventually not need a medicine to help you, but I'm going to spend a lot of time teaching you about what you really will need to have in place in order to stay clean once you get off of Suboxone. When it comes time, and we actually have a worksheet that we're building that helps a patient know when the time is ready for them to come off of Suboxone. Once it's the right time to come off of Suboxone, what we find is that tapering slowly off the Suboxone, and for someone who's on standard dose of 16 milligrams, it usually takes about 3 months, sometimes as much as 6 months, to slowly taper off, but that the process itself is not physically uncomfortable. At the very end, the very last 1 milligram to 0 milligrams, there is sometimes some insomnia that comes with getting off of buprenorphine, and it's temporary. It can often be solved with non-opioid, non-narcotic, non-sedative, or at least non-habit-forming medications with those patients temporarily, and it's really not physically difficult. The harder part is getting them to engage in treatment and recovery to a degree to which they can succeed without the help of buprenorphine. We always try to transition our patients from buprenorphine to naltrexone for at least 6 months after they get off of buprenorphine. It's not always, we can't always succeed at convincing patients to do that, but we always try. I would definitely say, and I think my patients who could say they've been through it would agree, that getting a patient who is ready off of buprenorphine is 100 times easier, 1,000 times easier than getting a patient clean off of heroin and keeping them clean. Much easier. I know I spent years getting people clean off of heroin and then trying to guide them into recovery, and my success rate was very small. much better with buprenorphine. So essentially, the value to me, considering all the things we've discussed here, the value of buprenorphine MAT and naltrexone MAT is engagement over time. The thing that really, really ultimately works in any kind of treatment is that the patient comes, they show up, they engage with you in an honest way over time. And that eventually, if they do enough of that over a long enough time, if they're being sincere, they'll make progress. What buprenorphine does is it makes that possible. It makes it possible for people to come in to treatment sooner than they might have otherwise. It helps them to get away from the lifestyle of getting high, of using, of breaking the law, of running out of money, getting sick, using again, and it stabilizes their lives, enables them to participate in treatment. And I believe that if it's done right, and this is where we all, I think, need to pitch in, being on buprenorphine MAT or on MAT in general can become a sure and steady pathway to the kind of recovery that we would want for anybody in our family. Not for everybody, but definitely a way to success. Like I mentioned, the most common misconception is that it's going to be easy, it's not going to take much time. I try to give my patients the perspective to understand that 10 years of treatment and slow, steady recovery is worth it, where people who with this disease struggle in and out of recovery and relapse for decades if they aren't able to get it right. Recovery definitely is a long process. When we think about the success cases we know, or that many of us ourselves have experienced, we have to admit to ourselves and to each other that it's a long journey, and it can often be a very painful journey. The physician health program is a very interesting example of a potential solution for patients to get recovery and to stick with it without the use of MAT, because right now most physician health programs across the country don't allow buprenorphine, but some do. Even though they're a good example of that, it only applies to extremely highly motivated patients who have ceded a lot of leverage to some kind of a monitoring agency. Most people will not volunteer for that. I've tried to sell it to patients, and I can't get them to join up. Finally, what we're seeing is that early on, the risk of allowing a vulnerable patient who doesn't have much recovery capital, doesn't have significant motivation, at least not enough motivation to really engage in recovery and in treatment in the way that we know that they would need to be able to make it, that their chances, our chances of losing them are so great that for most patients, just like ASAM is saying these days, for most patients who come forward for the first time asking for help from an opiate use disorder, most of them will benefit from being on buprenorphine. So my closing thoughts, it's a special time right now. The healthcare system is looking for an answer. Our political leaders are looking for an answer to addiction, the problem of addiction. There's been a system for a long time. There's been treatment for a long time, and it's helpful. It works. But we need to now take this opportunity to create a more comprehensive system that brings every tool that works together in an organized way in a way that we can develop a standard of care that we can share with our colleagues nationally and continue to improve. That we need to, especially those who have been involved in the treatment world for a long time, we need to make sure that we have a say in what goes into that standard of care. We can't leave it to those who maybe are over-investing in buprenorphine and MAT alone. Remember that the universal key to treatment, to successful treatment, is engagement over time. And that's the greatest value of MAT. It attracts people sooner, keeps them engaged, keeps them alive long enough to start that recovery journey, and they can make significant progress while on buprenorphine. Okay. Thank you, everybody. We got a little bit of time. Let's open it up for questions.
Okay. You talked about that in the disease of addiction, drugs is not the main problem. So of course there's underlying issues What do you see these days? Anxiety, depression, and how is that treated in your?
Yeah, I definitely see all of those issues with our patients. Most of the studies done on this find that there is about a 40% co-occurrence of mood disorder and substance use disorder. So in other words, 40% of those who have a substance use disorder also have a mood disorder. The percentage of people with mood disorder and substance use disorder is not quite as high, but it's many times more than the general population. So mental health issues like anxiety and depression, and we see both, bipolar disorder, definitely. Psychosis, psychotic disorder is not so closely linked to substance abuse as the mood disorders. We definitely see it. We feel like it is something that needs to be addressed with utmost urgency. You know, it's critical that it's addressed and addressed right away. It needs to be treated at the same time that addiction is treated. They need to be done in a coordinated way at the same time. That we want to be able to have a person maintain and sustain their recovery, they've got to have good mental health. Absolutely. But although we know that increases that having a depression or anxiety increases the risk of developing addiction, it definitely is part of the pathogenesis. We don't see treating the mood disorder as the key or the answer to curing the addiction. Both have to be treated. Both are primary illnesses. Yeah.
Something about while on Suboxone, I think you said 3 or 4 months after that, it kind of levels off. They no longer get that buzz.
Yeah.
Do you see a lot? That's when a lot of people say, well, I'm no longer getting some sort of a fix.
Yeah.
And they stop using it and go back out.
Yep. We do.
So
We do. We see both. We see those who are committed begin to really feel the benefits of group therapy and individual therapy and connection, and begin to make big leaps forward. And then we see a large component drift away and decide that this isn't fun anymore. But our feeling is, our attitude about it is that if we can give them a good experience while they were here, while we were exposing them to all of these good things in recovery, and most of them will go out thinking, I can handle it now, I'll be okay. When things go bad again, they'll find it easy to come back to us, and when we often see them come back. But yeah, that happens.
Thank you. The parents of kids who are addicted to opioids, what do you suggest is the best help for them when the child is in denial or whatever it is?
Yeah.
Maybe not so much what I hear in denial is like the child's reaching out for help. The parents are divorced and the other parent is like kind of muses. Yeah. So the child, but then there's the child kind of reaching out for help that's pulled this way, and like and not, this child is not well, 19 years old, and so like what do you suggest?
It's one of the most difficult things to face, and it's one of the hardest conversations that I have. We certainly do at VCAM try to engage the families of patients, especially young patients. And we see a lot of 19 to 26-year-old children, basically, who are still dependent on a parent or two parents to bring them in for treatment. What we do for those, what we try to do is invite those parents or parent to join in with us in our family program, so that they can start to learn about what they're dealing with, what addiction is, and how treatment works, so that they can be supported by other family members. We host Families Anonymous at our practice. And we teach them about how they can change the way they deal with their child in a way that will help encourage that child towards recovery. And usually that has to do with setting boundaries and enforcing boundaries, limits, and moving away from codependency and enabling, and moving towards addressing and dealing with the issue. If you have a split couple, a divorced couple, and one is engaged and the other is not, extremely difficult. Usually it will require either the two coming together for the sake of the child, or the one who cares being able to pull the child away from the influence of the one who encourages the bad behavior. Kids, it's especially hard for kids to learn those very difficult lessons that have to come together for them to embrace recovery, even if they're already saying, hey, I'm hurting, I need help, to be able to really put their arms around it and say, okay, I'm going to trust you, I'm going to do this program, I'm going to follow your advice. It takes time, but it has to start with their loved ones. It has to start at home. There's very little you can do to incentivize a kid who's enabled at home. The parents do usually make progress with us, but they find it really tough to be able to say, I'm sorry, I'm going to have to allow you to feel the consequences of this. And hopefully that discomfort will lead you to seek help and then make sure the help is there. And so we end up stirring things up a lot of times with dysfunctional families that have allowed the child to become so self-destructive. We tell the parents to make it tough on that kid. Go ahead, call the police if you have to. Don't hold back. If you got to do that, you got to do that. And then when they're hurting, and they finally realize, I can't keep living the way I'm living, we will be there, to help them make progress. It's not an easy answer, but we find that's the best way. Yeah.
You haven't mentioned too much about those that are addicted to alcohol and they come into MAT.
Yeah.
What is the effect, not only of the treatment, but you've got two separate addictions going on there, and one affects the other greatly. So.
Yeah, good question. And now, are you referring to people who have alcohol dependence getting on Naltrexone to help them stop drinking?
On any kind of medication, but that too.
Yeah, what we find, we definitely promote the use of Naltrexone among our alcoholic patients. But what we find in reality is that about half of those that use Naltrexone for alcohol feel like it's really helping them. They notice a difference. They feel like it reduces their cravings. They feel like it helps them that if they do slip, that they don't need to drink anymore. It's easier to not get too deep into a relapse. And they come back saying, hey, I can see how this Naltrexone is helping. Let's get that second Vivitrol shot, that third Vivitrol shot. Of course, all along the way, we've got them in the rest of our program with coaching, counseling, testing. If they've got mental health things, we're having them see one of our psychiatrists and so on. And so we definitely use a lot of Vivitrol and Naltrexone in our alcohol-dependent patients. Now, on the other hand, when you have a patient who has an opiate and an alcohol use disorder, we definitely try to tackle them both at the same time. We find that there are some things that you can go somewhat slow with. If the person is drinking, but not drinking in excess, not drinking in an alcoholic way, you can take a little bit of time to get them to stop drinking, and you can still keep them engaged in treatment. But if they're drinking in an alcoholic way, you have to address it right from the start. Or else, if you just focus on the opioid problem, the alcohol problem will get out of control. Yeah.
Some clients see it as two different problems.
Yeah.
They're okay. The alcohol's okay, but
Right. I don't have a problem with alcohol.
Right, that's
Right.
okay. So getting them that mindset change.
Yeah, same with cannabis. See it as that doesn't even count. It's not a real drug. It doesn't even count. I don't have a problem with that. If I would have just stuck with cannabis, I would have been fine. And I always feel like it's good to be honest with my patients, and I'll usually concede that, cannabis is a lot less dangerous drug. Yes, it's true. And a lot of people out there can enjoy it and have no problem, not get in any trouble. And yes, it's probably less toxic than alcohol, but you can't. You can't. If you use cannabis, you'll eventually go back to heroin, or you'll become such a pothead, that you'll become dysfunctional. I promise you. Sometimes they'll take it on authority, and they'll listen to me and believe me. Sometimes they have to test it out themselves. Yeah, but the key thing is we keep them engaged. That's kind of always our goal. Are they at least coming? Are they engaging? Are they going to their group sessions, their therapy sessions? Are they allowing us to test them? Are they talking to us? As long as they are, we feel like we're doing something good here, even if they haven't given up that marijuana yet. We still let them come. I was just talking about that with one of the psychiatrists that was here. We do, but we have kind of a process at our clinic of, we have phases of MAT where you're a beginner at first, you have to come a lot, you get tested a lot. As you progress, you get to have a little bit more time in between appointments. If you're using cannabis, you have to stay at the beginner phase. So we won't kick you out, we'll keep you there, but you're gonna have to come and see me every week and talk to me about it and tell me, so what was so great about the cannabis this week, and I'm gonna try to tell you to stop again. And usually we find people will eventually, they'll let it go, or they'll drop out because they get tired talking to me about it. But then they often come back, they really do. Yeah, very good questions. Any others? I'm trying to think of some of the questions that I was asked at halftime there to throw out there. I think that I got a question about how do you deal with patients who have a serious pain issue or surgery issue when they're on Suboxone or Naltrexone. There's a lot of different strategies to that. There's definitely solutions. I've had a lot of patients who have gone through surgical procedures while on buprenorphine. Our first strategy is always to try to keep them on the buprenorphine and use non-opioid things to get them through the surgical experience. Regional blocks, like if they're getting a knee done, use a regional block and then use non-opioid medications. I'll often try to max out their buprenorphine before I'll ever consider introducing another opiate. A lot of people nowadays are using high-dose opiates, and this is usually in more in health systems where they're more familiar with buprenorphine. They're using high-dose opiates in the hospital for acute pain on top of buprenorphine for just temporary relief of serious acute pain, but keeping the patient on buprenorphine through the hospital stay. In Richmond, at least, I usually find that if it's a serious surgery and they're going to be in a lot of pain, I usually have to take them off of buprenorphine. Use opiates, but keep them very close. And I always insist on managing their pain and then get them back to buprenorphine as soon as I can. Yeah.
I'm wondering, have you given any thought to differentiating mental health and mental wellness with existential wellness, something that's bigger than the individual, like as its own kind of entity, and the addiction to denial and ignorance that many adults have, so that we're not self-questioning, we're not seeking, we're not empathetic, we're not reaching out to the next generation, like the young climate activist who is seeing such a backlash against her mental illness when she is responding to an existential sense of crisis.
We definitely encourage, we do a lot of spirituality talk at our clinic, more than you would expect maybe for a medical clinic. And we talk frankly with patients about seeking a spiritual awakening. We try to leave it open to them how they'll do it, but we encourage them that if they're religious, to invest in religious practice. We tell them that, if they're not, to try out meditation. But that spiritual awakening is the greatest medicine to heal a person from addiction. We'll say that, frankly, even though it's not doctorly to say. We'll go ahead and say it, but recognizing that people do have to find it on their own. We feel like treatment makes the chances of a person having a spiritual awakening and recovery more likely. It's kind of like leading the horse to water and then allowing them to choose to drink. That's kind of the way we look at it. Yeah?
Do you go out to the senior area, especially maybe in the across the
we do see a lot of seniors come in seeking help. We have a lot of retiree age patients. One of the areas where we've had a lot of surprising success is for older patients who are, for the first time in their lives, having alcohol problems after they've retired and the kids have moved away and life is different now and it's boring or it's less fulfilling, less challenging, and now they're having a drug or alcohol problem. We get a lot of those folks coming in. So it was a nice surprise, and we have a couple of groups dedicated just to our older patients. One of my day jobs while I was building my addiction career is I was in geriatrics. and I was a medical director for a few nursing homes in Richmond. And I saw a lot of addiction there, a lot of incoming patients who came in with addiction problems. I saw a lot of patients in whom chronic illness or even dementia was the only thing that saved them from their alcoholism or their addiction. But I think that it's an area of great concern where there needs to be an expansion of understanding and exposure to treatment, because there's a lot of chemical dependency in the older generation that's a lot of times ignored, not talked about. Yeah.
This area, believe me, is
Here, yeah, sure.
it's below the surface. Not want to be dealt with.
Yeah. Yeah, thanks everybody. I'll stick around for other questions. Anybody like to ask, I'll be here. Thank you. Thanks for having me.